So I'm going to talk about the advances in lymphoma therapy. And Dr. Iyengar very nicely illustrated the heterogeneity of lymphoma, the various subtypes involved, and how we have to be mindful of that when we use imaging. The other variable is obviously therapy. And we can't deny that PET scans have dramatically changed how we modify therapy for patients or even used for staging and risk assessment. So I'll just go through some of the initial points about how PET scan has helped in terms of lymphoma therapy, and then go on to novel therapies and how in the context of novel therapies things have changed a bit and how we need more research in those areas. So these are just my disclosures. So I'll talk about a brief, just one slide to show how lymphoma has actually improved the management of PET scans have helped in the management of lymphoma in the recent years. Then I'll go on to pathogenesis of lymphoid neoplasms and talk about how the biology of lymphomas has helped us develop new therapies, how these therapies work, and therefore how they may influence how we use imaging to assess response, and some of the challenges we face at the end with imaging in the context of novel therapies. So in terms of FDG PET, we know that it's improved the accuracy of staging. As Dr. Iyengar pointed out, it's mainly the FDG avid lymphomas we use PET scans in, and we need to be aware of the ones that are FDG avid to be able to use PET scanning appropriately. It does highlight more extranodal sites than CT scans do, and it can upstage proportion of lymphomas that are FDG avid. It also helps in accurately identifying limited stage follicular lymphoma. And for example, previously we gave patients a potential long-term remission of about 50% with radiotherapy to stage 1 sites of disease. And that's improved to about 60, maybe slightly more, 60% when we accurately assess stage 1 using a PET scan and bone marrow examination. And then identifying biopsy sites for Richter's transformation, again, Dr. Iyengar referred to this. If we have an SUV max of over 5, we tend to identify that as a site of biopsy in somebody with CLL to rule out Richter's transformation. There's also an advantage in classic Hodgkin lymphoma where we can use an early response assessment in the context of ABBD chemotherapy, as shown in the RATTLE clinical trial, to risk adapt therapy or response adapt therapy, de-escalating or escalating as required after the 2 cycles of treatment. And then we know that a pre-transplant PET can be quite predictive of outcomes post-autologous or allogeneic stem cell transplant. And certainly at our center and a lot of other centers, I'm sure, PET scan is used as a pre-transplant tool to identify patients who are most suitable to proceed. So going on to the pathogenesis of lymphoid neoplasms to just try and understand how novel therapy is being developed. Lymphocytes, which are the cell of origin of most lymphomas, originate in the bone marrow. And so at the initial stage of development, there are these 3 genes, V, D, and J, that undergo rearrangement to produce on the surface of a lymphocyte what is a B-cell receptor. And once this B-cell receptor is exposed to antigen, it goes to the lymph node and undergoes something called somatic hypermutation. Now that means these 3 genes undergo hypermutation to produce a variety of different specificities to the antigen. And depending on how specific that combination of genes is to that particular antigen, cells become sensitive to that antigen and become memory B cells. Or if the specificity to the antigen is lost, they can actually undergo apoptosis. So it just highlights the importance of the B cell receptor in survival of the B cell. A proportion of B cells turn into plasma cells and produce antibodies. But as I mentioned, the B cell receptor, functional B cell receptor, is really quite important for B cells to survive and if not, they undergo apoptosis within the lymph node. And so at any stage during this process, this is just a normal lymph node, and this is the light and dark zones that you see within the lymph node. And at any stage during this process, you can develop malignant transformation of these lymphocytes. And so if it's early on, you get acute lymphoblastic leukemia, and then the more mature stages, you can see a variety of different types of lymphomas and chronic lymphocytic leukemia, which are the mature lymphoid neoplasms. And then at the later stage of development, you see Waldenstrom's lymphoplasmacytic lymphoma and eventually myeloma, which is a cancer of the plasma cell itself. So what's important to recognize here is just two things that are relevant to novel therapy. One, that the B cell receptor is really important for survival of these B cells. And the second is the expression of antigen on the surface of B cells through the development. And these three antigens on the surface, CD19, CD79A or B, and CD20, are antigens that are expressed throughout B cell development and therefore expressed in the counterpart malignancy in patients. So in terms of B cell receptor, what's happening within the cell is that as soon as antigen engages with B cell receptors, what we see happen is a cascade of events mainly mediated through two kinases downstream of the B cell receptor. One is PI3 kinase delta, and the other is Bruton's tyrosine kinase. That set off a chain of events that leads to NF-kappa B signaling and thereby result in proliferation and survival advantage for the cell. Now, two inhibitors that have been developed and are in clinical use currently are PI3 kinase delta inhibitors, idelalisib, umbralisib, and more recently ME401, which is in clinical trials, and BTK inhibitors, which target BTK or Bruton's tyrosine kinase. And there's a number of those now. Ibrutinib and acalabrutinib are being used and are NICE approved, whereas zanubrutinib and pirtobrutinib are in development. Zanubrutinib has actually recently received FDA approval in Waldenstrom's macroglobulinemia. So a number of these kinase inhibitors that block signaling downstream of the B cell receptor have shown impressive activity in certain lymphoid malignancies. And just to illustrate what happens as soon as a patient takes some of these inhibitors, and this is a case of CLL, in a patient who is taking a BTK inhibitor, you see this massive increase in lymphocytes because of a shift in the compartment from lymph nodes to the blood, because of the blockage of this BTK signaling, a dramatic improvement in the lymphadenopathy in these patients. And this is illustrated in this graph here, where the sum of the product of the diameters of lymph nodes drops dramatically in the first few weeks of therapy, whereas the lymphocytes actually shoot up initially, and then because they're losing the survival signals they get from lymph nodes, they die in the blood. And so over a period of several months, these patients go into remission, and this is a very well-tolerated medication. But some of the challenges this poses in terms of using our conventional methods of assessment like PET scans, and I mentioned that we conventionally use a cutoff of 5 and the SUV to check for transformation, is that when a patient's on a BTK inhibitor or a B cell receptor inhibitor and progresses on it, we actually see shifts in SUV max even in patients who just have CLL, so that they have much more avid lymphadenopathy. So if you look at this graph where SUV max is plotted against the different histological subtypes detected in patients who progress on a B cell receptor inhibitor, Richter's transformation, as expected, most cases are over 5 SUV max. But actually, now we start seeing that patients with CLL have a significant proportion of them have SUVs between 5 and 10. And so this can create a confusion in terms of diagnosis of Richter's transformation. And so biopsy is still quite important, but just be aware that we do see this sort of accelerated phase CLL in patients who are on B cell receptor inhibitors. And actually, it may just be CLL progression we're seeing rather than Richter's transformation, unlike with conventional therapy or for patients who are just on surveillance. Coming on to other modalities of treatment, so immunotherapy is obviously quite a big area of development, and a number of these drugs have been approved. And starting with antibody drug conjugates, this is a a sea hare, essentially, which produces a potent neurotoxin from which a synthetic compound called monomethyl orostatin E has been developed. And this, as I say, is a potent neurotoxin, but is also quite a potent neurotoxic agent, cytotoxic agent rather, which disrupts the microtubules within cells. And so two of the drugs that have been developed by conjugating this compound with an antibody against one of the receptors on lymphoma cells. So there's polatuzumab, which is directed to CD79B on B cells, and brentuximab vedotin, which is directed against CD30, which is an antigen expressed on some Hodgkin lymphoma cells, as well as some T cell lymphomas. And so what happens with this conjugate is that it has a protease cleavable linker, and when it is given as a drug conjugate conjugated with anti-CD30, it binds to the CD30 on the surface of cells, internalizes and releases the payload, which then disrupts the microtubule network and causes its effects. And again, both of these compounds are now licensed for use. This is an example of polatuzumab vedotin, a randomized trial comparing bendamustine rituximab to polatuzumab in combination with bendamustine rituximab, showing a clear survival advantage both in terms of progression and in overall survival. So just to show that these are the sort of advances we're seeing after applying the biology of lymphomas into therapy. But just a note of caution, this was something we published here on the right in a patient who had polatuzumab vedotin. You can see here that this patient was initially treated with RG-CBP, but then unfortunately didn't achieve a complete response, and so was switched to polatuzumab BR, and actually had a response in the splenic site, as you can see here, but then developed increased avidity in a previous site of disease in the pelvis. And that area actually was pseudoprogression that we saw, which we don't normally expect with polatuzumab. It's more commonly seen with checkpoint inhibitors, etc., but something that we confirmed with biopsy was actually pseudoprogression, and this patient then subsequently went into complete remission. So this is some of the challenges we face with immunotherapy. As you know, the immunotherapy that's probably most notorious for causing this sort of pseudoprogression is a sort of checkpoint inhibitor. There's a number of these now. This is a study of PD-1 blockade with nivolumab in classic Hodgkin lymphoma, probably the one malignancy where it shows the highest response amongst all solid tumors, with nearly 70 to 80% of patients achieving a response, although the complete remission rates are relatively low. But quite impressive responses in patients who were previously heavily pre-treated. And this is clearly a very active drug in this setting and is currently again licensed for use in the UK for classic Hodgkin lymphoma. But just going on to, again, if we look at response assessment, what's reassuring is that obviously the conventional responses, patients achieve complete response, are the ones who do the best in terms of progression-free survival. But what we do see is that we can continue this drug beyond progression and see an advantage in patients who continue beyond or are able to continue beyond progression because they're clinically well, compared to patients who come off treatment for progression. So actually, just imaging-based criteria to look at responses may not be optimal for these patients because a proportion of them actually do well if we continue this checkpoint inhibitor beyond progression. So again, some of the challenges here with immunotherapy that we see. Now, just to mention another important class of immunotherapy that is currently in clinical trials, and we'll very soon start to see some of these being licensed. Two really different types of antibodies. One is a bispecific antibody, which essentially has two specificities, one to T cells, the CD3 antigen on the surface of T cells, the T cell receptor, and the other to the tumor antigen. In the case of lymphomas, the ones being developed are directed against CD20. And then these antibodies have an Fc receptor and binds to NK cells, macrophages, etc. And two examples are mosunetuzumab and glofitamab. Mosunetuzumab has in fact just recently received approval from the FDA for follicular lymphoma because of quite impressive activity. And these can be given once every 2 or 3 weeks on an outpatient basis and do show some cytokine release, but apart from that are relatively well tolerated. And the other is bispecific T-cell engagers. Now, what these do is essentially the same as what bispecific antibodies do, but they don't have this Fc portion that we see with bispecific antibodies. Again, this is an example of blinatumomab, which is directed against CD19 and is currently in use in acute lymphoblastic leukemia and has shown some very impressive activity. Again, we do see some tumor flares with these patients, and the current trials do allow us to continue treatment even in patients who show radiologic progression, provided we think that they're benefiting clinically. So again, some differences we're seeing with response assessment with conventional methodology. The biggest advance really has been CAR T-cell therapy, and a lot of you will be aware of this. CD19 CAR T therapy is currently in use in the UK, and there are 3 indications. We use it for acute lymphoblastic leukemia, diffuse large B-cell lymphoma, and a couple of other subtypes, as well as mantle cell lymphoma, which is the most recent approval for CD19 CAR T. Essentially, this involves leukapheresis from patients where T cells are harvested, and then there's a retroviral transduction with an anti-CD19 chimeric antigen receptor, which then is expressed on the surface of these T cells. These T cells are then expanded and then reinfused into patients after preconditioning chemotherapy to achieve a response, anti-tumor response. And this has shown some very impressive results for patients who were previously heavily pre-treated, and so is currently being used on the NHS. This is a molecular structure. You can see this is the chimeric antigen receptor, which is an extracellular antigen binding domain, a hinge region, and an intracellular domain. And there are various iterations. So the first, second, and third generation CARs, which essentially the intracellular component can facilitate the persistence of these CARs or improve their proliferative capacity, etc. So a number of advances still ongoing in terms of CAR T therapy development. So 3 currently licensed products that I mentioned in the UK, and these are the 3 that, again, we're still evaluating the response assessments, but at the moment, there's no clear indication that we see false positives, but it'll be interesting when we have a larger cohort to study to see how conventional imaging works. This is the ZUMA-2 study. As I mentioned, mantle cell lymphoma is one of the other indications for CAR T therapy. Just showing the sort of design of the study where patients with relapsed refractory mantle cell lymphoma underwent leukapheresis, had an optional bridging therapy. They get a classic conditioning with fludarabine cyclophosphamide, and then the cells are reinfused. The first tumor assessment is generally on day 28. And we see some, these are patients who would otherwise have a very poor outcome, but we're seeing about 30 to 40% of patients with long-term remissions, with manageable toxicity in the form of cytokine release and some neurotoxicity, which, with more and more experience, we're able to manage much better. There's a number of interesting imaging parameters in terms of neurotoxicity, which obviously it's beyond scope of this talk. But this is clearly an interesting area of research and development, and we already are seeing the benefits that we can translate to clinic, and we're using some of these products that are licensed in our clinic. This is an example of a patient treated with CAR T therapy who had a partial response at 1 month and then complete response. So you can see a sort of delay in the complete response in these patients and then a persistent complete response going forward. So quite an impressive therapy in terms of the scientific translation of two or three decades of research in this area. So I'll just end by summarizing some of the challenges that we see with advanced lymphoma therapy. So we've got FDG PET, as I mentioned, which has helped us improve staging and therapy in terms of response adapting treatment. We've got novel therapies, but they do have an effect on false positives on PET scanning. Some of these have been addressed in the lymphoma response to immunomodulatory therapy criteria, or the LYRIC criteria. But clearly we need better techniques to assess response in the context of novel therapies. I think this is where further research is needed, and multimodal assessment, including things like circulating tumor DNA, would probably be the answer. But we need to do this as an urgent sort of priority, because treatment is rapidly changing. And this is just, I'm just going to end with this diagram where it's a review that we published in Nature Reviews Clinical Oncology, just looking at the future of where the biggest questions will be. Just if you look at this bottom diagram, we felt that the key areas are to find out what the optimal combination of new tests. We clearly need a combination of clinical, biochemical, histological, and genetic profiling. But which tests are most likely to inform what treatment we choose is important. How we assess staging and response is important. What is the desired rate and depth of response? It's different for every different treatment we use. How often should we image, and how should we interpret these results? And can we discontinue treatment, because a number of these new therapies are continuous? And do we need to consolidate, or should patients receive maintenance? So these are the big questions, I think, going forward. I'll just stop there, and thank you all for your attention.